All right, welcome back. Today, we're diving into a high-stakes investigation into the microscopic world of urine sediment. Yep, you heard me right. This is where tiny, tiny clues can solve major medical mysteries. And look, knowing what to look for is absolutely critical, especially when you're staring down exam day. So, I want you to picture this. You are the lead detective on the case. You've got your sample, your microscope is perfectly focused, and the evidence is right there, staring back at you. Every single cell, every crystal, every cast, it's a piece of the puzzle. And your job is to read these clues and piece together the patient's story. So you ready? Let's dive in. Okay, here's our game plan for the investigation. First, we'll set up the crime scene. Then, we'll identify the usual suspects. We're going to decode messages straight from the nephrons, run a full cellular lineup, look for any other clues lying around, and then finally, we'll put it all together to crack the case.
So let's be really clear about this from the get-go. We are not just passively observing here. Nope, we are actively gathering evidence. Every single field of view under that microscope is a potential crime scene. And figuring out what's normal versus what's a major red flag, well, that's the first step to any good diagnosis.
You know, every good detective, any detective worth their salt, knows you can't spot a clue if you don't know what the scene is supposed to look like in the first place, right? So first things first, we need to establish our baseline. We need to identify the usual suspects you'd find in a totally normal, healthy sample.
All right, this right here, this is your baseline. This is what normal looks like. So under a high-power field, that's your HPF, it's totally fine to see, 0 to 2 red blood cells, maybe 0 to 5 white blood cells. Now, if you switch over to a low-power field, or LPF, finding a couple of hyaline casts is also perfectly fine. A little bit of mucus, also totally normal. Think of these as just the background characters in our story. But listen, you got to memorize these ranges. They are your absolute reference point for everything else we're about to talk about.
Okay, so we've got our baseline down. Up to 5 white blood cells per high-power field. No big deal. But what happens when you see more? A lot more. What does it actually mean when that count is elevated? Well, this is where our investigation really kicks into high gear.
And here is a critical term for your boards. You've got to know this one, puria. If you see more than 5 WBCs, it means the body is fighting something. We're talking inflammation or infection. Seriously, alarm bells should be going off in your head. This isn't just some random finding. It's a direct signal that there is a problem.
Okay, now this is a classic exam-style trap. You're looking down the scope, and you have to differentiate a WBC from yeast. They can look super similar, but their stories completely different. WBCs tell you there's a host response, an immune reaction. Yeast, on the other hand, is often just a contaminant, maybe from a vaginal infection. You mix these two up, and your whole investigation could go off in the completely wrong direction. So be careful here.
All right, let's move on. We're going deeper now, right into the kidney itself. And this is where we find one of the most important clues in any sediment analysis, casts. I want you to think of them like molds, or fingerprints even, that are formed right inside the kidney's tubules. What's so amazing is they give us a direct message, a little postcard, about what's really happening inside the nephron.
So here's the crucial part. The type of cast tells a very specific story. You see a red cell cast? That points to bleeding right in the glomerulus. So you should be thinking glomerulonephritis. You see a white cell cast? That tells you the infection is way up high, inside the kidney itself. We're talking pyelonephritis. And what about granular or waxy casts? Well, they suggest things have been slow for a while, a sign of chronic kidney disease. See? Each one has its own story. Okay, listen up. I want you to burn this next phrase into your memory. If you see a red cell cast on an exam, your mind needs to immediately, and I mean immediately, jump to glomerulonephritis. It is the single most definitive, non-invasive clue for glomerular damage you can get. It is, without a doubt, the smoking gun of the case.
All right, we've analyzed the casts, we've got their stories. Now it's time to bring in the cells for questioning. That's right, it's our cellular lineup. We need to figure out who's an innocent bystander and who are the really significant players in this drama.
So here's our lineup. First up, we've got squamous cells. They're these big, irregular-looking things. Honestly, they're usually just contamination from the skin, so they're the least significant. Then, we have transitional cells, from the bladder. These are worth a second look, for sure, because they can indicate malignancy. But there's one cell in this lineup that's our star witness. And I'm telling you, it is by far the most critical piece of cellular evidence you can possibly find.
And this is it.
the renal tubular epithelial cell, or RTE. This is the one you absolutely cannot afford to miss. Why? Because these cells literally line the kidney's tubules. So if you're seeing them in the urine, it means the tubules themselves are being damaged. This is a direct, major clue for serious conditions like acute tubular necrosis. You find these, you found a huge piece of the puzzle.
Now check this out. You take that same RTE cell we just talked about, and you stuff it full of fat droplets. What do you get? An oval fat body. And here's the really cool part, the part you'll see on your boards. Under polarized light, they have this beautiful, unmistakable Maltese cross pattern. It's a hallmark, a super high-yield association for nephrotic syndrome. So remember, see the Maltese cross, think nephrotic syndrome. Simple as that.
But wait, our investigation isn't over yet. Beyond the cells and casts, the urine can be full of other microscopic evidence, like crystals. And these little guys can tell us all about metabolic problems, liver disease, or even inherited disorders.
Now look, a lot of crystals are totally normal, no big deal. But these are the ones you absolutely have to know for your exams. Tyrosine and leucine crystals, that's bad news for the liver. Cysteine crystals, those really cool-looking hexagonal plates, they point to a metabolic disorder. And bilirubin crystals are another really clear sign of liver damage. The shape here is everything. Each one tells a completely unique story.
And here is one more piece of evidence you just can't miss. It's called a clue cell. Now remember how we said squamous cells are usually insignificant? Well, this is the exception. It's a squamous cell that is completely covered in bacteria. It almost looks like it's been peppered. This isn't just contamination, folks. This is the diagnostic calling card for bacterial vaginosis. See this? You know the diagnosis.
Okay, deep breath. We've gathered all our evidence. We've got the cells, the casts, the crystals. The final step in any good investigation is to step back, look at the big picture, and see how all these individual clues come together to form one single coherent diagnosis.
So let's do a super quick, rapid-fire review of the absolute must-knows for test A. You ready? Red cell casts, glomerulonephritis, renal tubular cells, tubular necrosis, white cell casts, pyelonephritis, tyrosine and leucine, liver disease, and oval fat bodies with that Maltese cross, nephrotic syndrome. Got it? Good. Lock those in.
So here's the most important point of all this. Identifying these things under a microscope. That's step one. It's a vital skill for sure. But the real art, the real science of medicine, and what your exams are really testing, is your ability to take that microscopic finding and connect it to a real-world patient and their whole clinical story.
So now you can spot the evidence. You know the difference between an innocent bystander and a stone-cold smoking gun. But the question that I want to leave you with is this. How do you take all these separate little pieces of information and weave them together to build the final definitive diagnosis for your patient? Because that's the next chapter in your investigation.